Thank you for listening to Scrubbing In. I'm Todd Schlosser, and joining me today is Mauricio Garrido. And he is the clinical director for cardiac surgery at Abington Hospital, Jefferson Health. And the reason I brought you here today is I'd love to talk to you a little bit about your general upbringing through the medical field and sort of what led you to where you are today. But I'd like to start out with what got you into the field of medicine in general.
Well, thank you very much. I've been now out of training for about 11 years, and I really didn't think I was going to go into medicine up until pretty late, right before starting college. My training is in engineering and chemical engineering.
Oh, okay.
My degree is in that. But right before starting college, I had been through a period of time where my dad ended up having a coronary artery bypass.
Oh.
And I didn't know anything about medicine at the time, but my dad had been sick. At that point, I was entering college. My dad was diagnosed with coronary disease at age 8, my age, 8, and he had diabetes, coronary disease, and I saw him kind of deteriorate over time.
Sure.
Have multiple heart attacks, and I can see what effect that can have on a family. And then when he had the coronary bypass, I saw the gravity of the operation, but I also saw how well he was able to recover. And over the long run, I could see that he could go back to work. He had no angina. It allowed him a new lease on life, and I thought that was wonderful. That kind of planted a seed, just recognizing the ability that we have as caretakers, as perfusionists and OR teams and nurses, and to be able to change people's lives and affect families. And these are pinnacle events that happen in patients and in their families' lives and the patients' lives. And it was a big event for me. And so I looked at medicine very early on in college and was able to proceed and get a degree in chemical engineering, specifically focusing on fluid mechanics, which has been perfect for my field. Yeah. So I'm very in a unique position in that the chemical engineering background gave me a broad science background, and they kind of meld well. So that's one of the things I like about what I do.
Now, when you got the sort of engineering focus, was that at Cornell?
Yeah, that's right.
And then, sorry, I did stalk you a little bit on LinkedIn before this. I like to do my research.
Sure.
And then you went to Yale for medicine, correct?
That's right.
Is that right? So, and that was, and you, I guess, finished it about 11 years ago. You say you've been practicing for 11 years, or did you get a residency after that?
Yeah. So the sequence is it's 4 years of college, 5 years of medical school, just because I did a thesis in the meantime as part of the program there, and then it's about 6 years of general surgery training, including a research year. Okay. And then after that, you become a general surgeon. But then you can go on, which I did for a cardiac surgery fellowship, which is 2 years. In addition, after that, it's six months of specifically LVAD training, so mechanical cardiac assist program training. Yeah. And that's when I started working. So it's something, when you go into surgery and you go into cardiac surgery, by the time you hang up your first shingle of your first job, many people have had the first part of their career already done. And so it's a little bit different for us. Yeah.
So let me ask, and not to touch on too sensitive a subject, but with your dad and his health issues and that leading you into that, does that give you, do you think, a different outlook than most people coming in? Yeah. Because you're focused on not only, you saw how it impacted your father, but also your family. So it's not just the one person who's having sort of their worst week ever. It's their family who's also struggling with them. Yeah.
There's a couple of things I remember specifically from that time. I was young, granted, in high school, but I remember, the how difficult it is to be waiting during the operation. Yeah. And I also know that during that whole period of time from age 8 until 18, my dad was in and out of hospitals in the emergency room, and I remember that that many people would come in, that they were attendings or what have you. I had no idea at the time. And they'd speak with a lot of confidence and kind of say, to my dad, you'll be fine. We'll get you through this. And then they went on their way. And in reality, the people that I felt most comfortable with were probably, I'm assuming, either a fellow or resident that would come in and have a look of concern. Yeah. And in that, it helped because it gave me some solace that this person's coming in realizes this is a serious thing, whether they think it's fine or not, it doesn't matter. What's important is that they're concerned. And I really am grateful for that because it helps me to keep that in mind from the patient's perspective. Yeah. We see patients every day and we operate on them every day, 5 or 6 times a week. And the truth is that all those patients are very concerned, and it's our responsibility to approach it with the same level of concern, but on a foundation of experience and expertise and teamwork. Yeah. So that's important.
I think, and this has not been my experience in dealing with surgeons or things like that. And my father too has had some health problems, and I've had to be at the hospital with him, and so I've been on that side of it. And the sort of pop culture thinking of a doctor is sort of cold, and especially a surgeon, sort of cold and dispassionate in their bedside manner, if that's even an appropriate term anymore for that, is sort of very business, if that makes sense. Not dispassionate, but business. Sure. And I would imagine that having been through what you've been through and seeing it from that side, it allows you to have a different sort of outlook on it.
Yeah, if I didn't have that experience I had with my dad, it probably may have changed my temperament. So I'm very grateful for it. Yeah. And there is a public's view of what cardiac surgeons should be about, but I'm here to let you know that there's the whole gamut. Yes, there are people that are very businesslike and abrupt and so forth, but on the other spectrum, the people that take a lot of care to do the right thing, not just for the patients, but for the people that they work with. Yeah.
And I was listening to the specialty care CEO talk, I think it was last week, about how everyone who's in surgery with you, not only you and your chief perfusionist and your anesthesiologist, but also the nurses, and if you're using anyone from intraoperative neuromonitoring, that sort of stuff, they are all touching not only that patient's life, but that patient's family and their community, and ultimately you're touching this large group of people anytime you're in there operating on anybody. So that I think viewpoint helps us and help me to understand not only just the stakes, but the impact that one person in surgery, not necessarily just the surgeon, but one person can have in that.
That's very important.
And I wanted to talk a little bit
Recognize
about
that.
Yeah. I wanted to talk a little bit about the importance of the team that you build. And I imagine as the cardiovascular surgeon, you are seen as the leader of that team. I've heard it often compared to sort of leading a symphony, being the conductor of a symphony, because you have to trust everyone to do the job they're there to do. Yeah. But you still are sort of in charge of making sure they do it. So can you talk to the importance of building a just professional and strong team, and experienced is the word I was looking for.
Well, I can tell you that it's not uncommon for me to round on the service or see patients when they come back to the office 3 weeks afterwards, and they'll say, "Oh, doctor, you saved my life. I'm so grateful for what you did." And if they're an elderly patient lady, I often joke a little bit and I tell them, well, it's really about 30 people that are involved intimately in your care, and each one of them have contributed to you getting to where you are now. And I tell them I'm just the good-looking spokesperson for the group, and they get a kick out of that. But there's some truth. There's a lot of truth in that. It's common for patients to associate the surgeon as being the primary vehicle in the whole thing, but the truth is that it's a team. We work together. I depend on them as much as they depend on me. Ultimately, I take leadership. I take responsibility for the outcomes that happen, both good and bad. Sure. But at the same time, I recognize that each member of that team, it's not a big team, but it's a cohesive team that I've worked with my whole time that I've been there, 11 years. I'm dependent on them on addressing the issues and catching the issues, not only under their responsibility, but other people's responsibility. So we work together and help each other to get the patient safely through there. I think that the idea of having, one leader that orchestrates from the top and everybody just follows, orders, that's antidote. That's not. It's almost an anachronism because there's too much data going on. There's the complexity of cases is high, and we need to be able to allow independent thought and independent leadership to be able to deal with issues as they happen. So sometimes the surgeon is not the leader. Sometimes there are scenarios where I have to defer the expertise to my anesthesiologist for something that she's strong with or he's strong with. I have to get expertise from the perfusionist. Ultimately, as a surgeon, I'm responsible, but you allow people the ability to move with independence. That's very important.
That is very important. It's actually a good quality of a leader is to trust those that need to move, as you say, or think and act quickly. Allow them the space to be able to do that.
Yeah, it's an important factor.
Yeah. So let me ask, when building a team, the things I think about are, when building a strong team are things like communication. And I wanted to talk to you a little bit about that side of it. So fear a lot of times can come across as anger.
Sure.
And I imagine there's almost no higher stake situation than when you have a patient's heart stopped on the table.
Sure.
And you're doing the work that needs to be done to get them back to where they need to be. So in that situation where there's could be perceived a lot of fear, does that ever come across as anger? And how do you deal with the emotion that comes with that? Yeah,
it's tricky. So the issue of having concern at a different point in time, surgeons like to use the word concern instead of fear, just to look cool. But
it's probably also a better way of framing.
Yeah, but the truth is that there are things that happen that are unexpected in the operating room or outside, and your inner dialogue during that is pretty intense. You have a lot of things you're considering. What could be the cause of this? How can I reverse it? And my belief is that, at least with the group that I work with, that you can lead the tenor of what's happening. You can your affect and disposition, and that's important because you maintain your calmness and allow things to be clear and decisions to be or ideas to be thrown into the mix with order. That can save a patient's life. Yeah. I've seen it go in both directions. I've seen it when the energy level starts heightening and there's a lot of yelling and excitement and so forth, and then people make mistakes and there's bad outcomes that happen from that. I've also seen it where someone wants to show grace under pressure, but so much grace that there's no movement, and you have to strike a balance. Yeah. It just turns out with a team that I've worked with, we resonate really well, and like I said, we've been very consistent for the 11 years I've been there. Yeah. So we've learned a lot over time how we deal in adverse situations. So it doesn't come as unfamiliar, and that helps. So we tend to be maintained pretty calm during emergent situations.
I'd imagine calm is where you want it to be.
You want people to be able to be at their best, and there are scenarios and teams where I've been in that in the past, not here, where in order to get people to be their best, you have to be loud or abrasive and so forth. It just happens that the way we've grown together as a group, we realize that that's not helpful, and it's just not my temperament either. So it ends up being for the better with my group.
So you've been with your current team, and I'd imagine some team members come, some team members go in this 11 years that you've been with them. But during that time, I'd imagine there's a comfortability that develops between you and your chief perfusionist, who we also had the benefit of interviewing, or your anesthesiologist or neurophysiologist if you're dealing with them. Sure. So are there benefits of having a team that you work with a lot? And I guess the only thing that comes to mind right now, although I'm open to you having other benefits, but sort of the nonverbal communication, them sort of being able to anticipate your needs and yours theirs. Does that sort of stuff develop over time?
Yeah, it does. I think the best way to lead that is to take the first step in acknowledging where your shortcomings are. Sure. So I'll give you an example. If you look at aerodynamics with human factors in the operating room or elsewhere, a common way that distraction can cause problems is if you have a series of steps you're supposed to take, A, B, C, D, E, and you go through A, then you go to B, and then there's some unexpected distractor. An event happens, something distracts your attention for a moment, then you come back. I have a tendency of moving on to D instead of C. And so I'm very clear with my staff and the people that I work with that that's where my cognitive overload can happen. When I'm managing what's happening and something unexpected happens, I'm dealing with it. So they're very quick to know to make sure that I'm there and I stay on point with it. Same thing can happen with the perfusionist. If the perfusionist has a scenario where they're taxed and they're working with a student and working to get them through the teaching and so forth, or there's a very quick change in what's happening, my perfusion team is phenomenal. They can deal with quick change as well, but I recognize that when that's happening and they're in a teaching stage there are multiple things going on.
Yeah.
So I'm recognizing of that. I recognize that, and we learn to support each other. So you have extra eyes on the situation. And that goes across the board between nursing, anesthesia, perfusionist, and first assistant and cardiac surgeon.
That brings up another question that I have. You as a surgeon, maybe more than anyone else in the operating room, your job is to focus on the patient, to get the patient working. But that one focus is impacted by everyone else who's in the room. So how important is it that everyone be working at the same, in unison, not to go back to the symphony motif, but to be working in unison so that you can do the job that they want to do. And also that would help, you can impact what the perfusionist does. So how important is that? It's
very important because it's, you're taking on, if you're going to operate effectively and efficiently, you need to be able to focus on the task at hand and coordinate the four hands that are working together between the surgeon and the first assistant. The benefit of the position that I'm in is that I've developed a rapport and a working relationship with all the people that I work with that's been tried in the fire at times. And because of that, trust builds. And with the trust, that they will address issues as they happen. They'd let you know if things are coming that are outlier, that stand out early, outliers. So it allows me to really focus on what I'm doing. When I first started, fresh out of training, I could, a lot of my thinking was distracted by sometimes doing someone else's job. And over time, you develop that trust. It doesn't mean that you're forgetting of it or you just focus on what you're doing. It allows you the opportunity to, have people be ready to tell you what's happening in real-time fashion. That's one of the benefits of specialty care. The team that I have is phenomenal, and they bring in the latest, most up-to-date ways of taking very complex data in real time that's relevant and synthesizing an analysis of what's happening physiologically with the patient and bringing it to me, either through the Connect system, which is a very great system that allows us to really get real-time data with oxygen utilization during the pump run, CO2 uptake, and so forth. All these things allow us to not dumb down the cardiopulmonary bypass circuit, not dumb down the physiology of what happens, but at the same time not be overwhelmed by too much data. That can be very distracting. The most difficult part of that, I think, would be to not overload you. But to give you every bit of information you need to be able to do what you need to do effectively. Not just me, but to the anesthesiologist, to the nurses, to each other, for the perfusionists. I mean, there's one set of information moving around. We communicate, everybody hears it. So if it's okay, I'd like to close with just one question. And that would be around morale when it comes to teams. So building team morale. Because when you have good days, those days have to be great because you're dealing with the extremes. So you save someone's life and you have the best outcome. The other side of that is sort of a negative outcome that's, that can be I'd imagine, very demoralizing. So how do you celebrate the successes and how do you help your team bounce back from those rough outcomes? That's a good point. What I recognized early on is that the people that work in the operating room, in particular the perfusionists, the first assistants, the circulating nurse and the scrub nurse, they are integral to what happens, but they almost never, if ever, get a chance to really see how these patients are at 3 weeks, 4 weeks out when they come up for the post-op visit, and they're grateful. So we have a process of bringing them up to see the patients there. I think it's important for them to see that. At our hospital, the Jefferson Health, in terms of its values and mission and vision, innovation is a huge part of it, and thinking differently is a big part of it. So, for example, in our operating room, when we're beginning to close, and there's still, probably about 30 to 40 minutes in the operating room before I would go up and see the family. We set up a HIPAA-compliant video link to the waiting room. We realized that the last 45 minutes, almost exponential growth of stress for patients and for family when they're waiting. I knew that when I was waiting for my dad. So we make a video link through HIPAA-compliant to an iPad that's in the waiting room. That's actually in the patient's room where it's private for the family. And for about 30 seconds to 45 seconds, they get to see my staff, me, nothing gory. So from the chest up, I tell them we replaced the valve. We made the 2 connections. I'm very happy with the way things are going. He's still in critical condition, but I'll be up in about 45 minutes. You can visibly see family members relax.
Just relax, yeah.
And the secondary, it's got a lot of press. A lot of people I've had a lot of hospitals across the U.S. calling me about that same program.
Yeah.
But the real nice thing is that the staff actually get to see the family members and how appreciative they are.
Yeah.
And the family members get to see them. So I think that's very good. And as far as morale during difficult times, you really, really prove who you are as a leader and as a surgeon and how you handle the difficult times. You can be push blame other places.
Sure.
You can be quiet and avoid the discussion, or you can have a real discussion about it. So, in the situations where unfortunately a patient would die, even in the operating room, we have a agreement that we'll meet the next day in the same operating room with everybody involved to go over the issues, see what we could have done better, but also for an ability for people to debrief. Yeah. These events affect all of us, and part of the process of building morale is to help each other during that. So that's important.
I mean, I'd imagine it may be not the same as grief, but you're dealing with what happened, and it was a big event. Even if you didn't really personally know the person who was on that table, it's a big event that you've got to work through in order to get back on the horse, if you will, and get back into it. Yeah,
I recognize very well what it's like to make a decision or do an action that results ultimately in the death of a patient. And part of our training through general surgery, cardiac surgery, is to be able to see that squarely and be able to make decisions so you can help the aggregate number of people you're going to treat in the rest of your career. I also recognize that for members of my team, there's a lot of responsibility I put on them. Yeah. And so when something goes wrong or goes poorly, part of that is protecting them in the sense of, this is community. We decided on this community as a community to do this, or as a group to do this treatment and do what we did. We'll learn about it as a group, but no one individually is held, as a primary source of that problem. And we talk about actions and less so individual ad hominem, attacks on people. That's not going to work.
Yeah, so you got to focus on what is beneficial in the situation we're in now.
Correct.
And get rid of the things that aren't.
That's exactly right.
Well, thank you so much for doing this. I can't think of a better way to end this. But Dr. Garrido, I appreciate it very much. Thank you so much for joining us on Scrubbing In.
Hey, thanks. That was great.
Thanks.